Welcome to my latest how-to series, and this is all about how to handle dilemmas surrounding medication use in recovery. I'm Dr. Steve Grinstead. I've been working with people with chronic pain and coexisting disorders, including addiction, since about 1984. One of the biggest struggles I end up with, and most of the crisis calls I get from other healthcare providers, is how do I identify and manage medication use problems in recovery? So let's start talking about how do recovery and medication fit? Well, first of all, the first question is really important. Why people in recovery use medication? And there's a lot of good reasons. Sometimes people develop a medical condition and they need to be on appropriate medication management. If the person's in recovery, though, if this medication tends to be mood altering, whether it's antidepressants, opiates, tranquilizers, whatever, anxiety medication, they better have a plan and an exit plan. Some people have chronic pain, or they get acute pain from an injury. Again, same thing here. People need to have a plan because it's really important. Otherwise, if the person's in recovery, it can lead to relapse. Some people do get injured. And just because you're in recovery doesn't mean you'll never get injured. And I think there's two major traps for people in recovery around pain and injury. The first is the obvious. They take the wrong thing or too much of the right thing. But the second one can lead to every bit as many relapses, if not more, and that's having the attitude as I can't take anything no matter what, and they end up suffering. And then some people do it because they want to get high. They want to cope with their painful reality or escape from their painful reality. So it's really important to define some terms, addictive disorders, recovery, and some red flags. Knowledge is power. The more a person knows, the better they're going to be able to manage their problem. Unfortunately, though, some people have all the knowledge in the world, but they don't activate it. That's why I love this quote, and I traced it back. The first citation I can see on this particular quote is from John Quincy Adams. And he says, "A little knowledge that acts is worth infinitely more than much knowledge that's idle." So it's about helping people get into action, especially if they're in recovery and they need to be on medication. Along this theme of knowledge is power, a lot of people have a lot of misunderstanding about an addictive disorder and how people get it. It isn't you start using and you get addicted right away. There's stages, and there's some high risk factors. When people have the initial experience, the initial use of medication, a lot depends on what their genetic or environmental predisposition is. If a person has a family history, for example, of alcoholism, addiction, mental health, they're at higher risk for having a different response. If genetically the person has a reward deficiency syndrome coined by Dr. Kenneth Bloom, they're going to have a completely different experience from the first use of their medication. Now, if they also live in a toxic situation or living with debilitating chronic pain and it's not being managed effectively, that will also impact how fast they speed through this continuum. With ongoing exposure, people in the high risk factors, they immediately move into what I call seeking and reaching, or this is doctor shopping. So they have learned that, wow, this stuff really does something for me. I can't do without it, and it's much more than what they were supposed to be taking it for. Over time, a lot of these medications, people build tolerance. It starts taking more to get the same effect, and then they enter the danger zone. This is where a lot of people start abusing their medication, and they might develop what's called pseudo-addiction. And to put it really simply, we're going to talk about this later, but pseudo-addiction is undertreated or mismanaged chronic pain. Now, if they don't get a handle on it here, they can move into a full-blown addictive disorder, and people die from this disease. So what are some of the prescription drugs of abuse? Well, let's start with, a lot of times there's a big problem with non-medical use of prescription medication. The Center for Disease Control talked about emergency room visits for opiates going up over 110% in a short period of time. The most common of these pain management meds were oxycodone, that includes the OxyContin, hydrocodone, which is like Vicodin, and methadone. All these increased during that 5-year time period. But that's not all. Emergency room visits for benzodiazepines went up almost 90% during that same period. What we're seeing lately is a lot of people overdosing with opiates. They lead all the drug overdoses. In 2010, over 38,000 drug overdose deaths were recorded in the United States, and well over half of those involved pharmaceuticals. And guess what? The most common were the opiates, and a distant second were the benzodiazepines and then antidepressants. But guess what? When the leading cause of the overdose was benzodiazepines, over 77% of the time opiates were also there, and same for these other medications. So opiates are becoming a very big problem. Some of the other commonly abused pain drugs: alcohol, marijuana, methamphetamine, and now heroin. Very common: hydrocodone, Vicodin, Loratab, etc. Those prescriptions were skyrocketing, and last year they finally got put on Schedule 2. OxyContin and oxycodone are still getting some high press. Demerol and Dilaudid, these are the medications a lot of people want to go to emergency rooms or urgent care centers to find. Exalgo. This is very similar to a drug that got pulled by the FDA back in the early 2000s. It's a very powerful medication, hydromorphone. Opana, a 12-hour extended release. I'm starting to get more horror stories about this one. Morphine and codeine. And then recently, over the last several years, methadone's been being used a lot more in pain management, but a lot of people are really abusing it. And some people are taking benzodiazepines with it, which can be lethal. And then don't even get me started with the new generation of sleep meds. You know, things like Ambien and Lunesta. One of the more common co-occurring problems with people living with chronic pain is sleep disorders. So a lot of people have prescriptions for Ambien or Lunesta, and they take it every single day. And that's not a good idea. It was never intended for that. And then we have some of the supposed non-addictive pain meds like Ultram or Tramadol. Now this medication is almost identical to an opiate. It hits the same receptor sites as opiates. People in recovery should not be using this without a very good plan. Then there's Soma, the benzodiazepines. You know, we've had a long track record in this country with that. Valium, and then Xanax, Ativan. Over-the-counter medications. A lot of people have a mistaken belief: because I can buy it without a prescription, it's okay. Well, guess what? A lot of these have acetaminophen in it, and some of the other medication you're taking may too. It'd be real easy to go over the daily dose. And then for people in recovery, a lot of these, especially cold and flu remedies, have ephedra and alcohol in them. Now, I want to talk now about some misunderstood terms. Now, years ago, about 12 years ago, the American Academy of Pain Medicine, the American Pain Society, and the American Society of Addiction Medicine were presenting at a conference. And on their paper, I took out some different misunderstood terms that I want to share with you. Tolerance, physical dependence, addiction, and pseudo-addiction. These are very misunderstood. Mental health, addiction, and pain management see these differently sometimes. Pain patients definitely don't have an accurate understanding of what these are. So I thought it would be real important just to touch on these. And then we have this condition called opioid-induced hyperalgesia. People that are taking opiates for a long period of time may find out that the medication they're taking is causing a lot of the symptoms they're feeling. So let's start with tolerance. I just want to focus on the earth language though. You know, when you first started using your medication, it only took 1 or 2 pills to get relief, and now it takes 4 or 5. That's building tolerance, or that state of adaptation. Physical dependence. So to put it simply, when our bodies get adapted or used to taking medication on an ongoing basis, that's the normal state. Then when you stop taking it suddenly, you get sick or go into withdrawal. Now, a parallel process here. Somebody who is a diabetic and they're on daily insulin. I have never ever heard anybody called an insulin addict, but they definitely are insulin dependent, and if they stop taking their medication, they're going to get worse. They're going to have a relapse for their diabetes. Addiction. This is one of the better definitions. It's been updated a little bit since 2004. Last year, the American Academy of Pain Medicine came up with a new definition. It's a primary chronic neurobiologic disease with genetic, psychosocial, spiritual, and environmental factors. You know, it definitely impacts the whole person. But to put it really simply, it's, you know, when somebody's taking medication for reasons other than that physical analgesic pain relief, and they won't or can't stop, even when they're told bad things are happening, they're probably addicted. But it might be pseudo. So the pseudo-addiction, one of the common definitions is behaviors that occur when the pain's undertreated. It can also be when it's mistreated. And they may exhibit a lot of these addictive-like symptoms. You know, they're running out of meds, they're always anxious near time at ending dose when it's supposed to be time to take the next dose. They may start using other things to enhance the medication. But really, a lot of times it looks a lot like addiction. They may appear to be doing that med seeking or drug seeking. They may run out early and need early refills, but it could be caused by mistreatment or undertreatment. And when it gets addressed, when the pain gets addressed, those problematic behaviors will disappear. So opioid-induced hyperalgesia. And there's more research. This is from 2009, but there's more current research on this too, but this is one I particularly liked. To put it really simply, the meds you've been taking to help you manage your pain is actually causing your pain to get worse. A hypersensitivity to pain signals might be another way of saying it. So what do people need to do if they're in recovery and they need to be on medication? Well, they need to have a multifaceted plan. They need to be working on their physical self, diet, nutrition, exercise, avoiding problematic foods, having good stress management, good hygiene, etc. But they're not done. They also need to be working in the psychological area, ways to manage problematic thinking, uncomfortable feelings, how to make effective, safe, and better decisions. And then we've got the social, how to interact with friends, family, and community in a healthy way. And then the glue, I believe, that ties together is the spiritual, not the religious, but the spiritual. So people need to find, what are my spiritual values, principles, and practices? And how congruent am I with implementing those? I also believe that people must be active participants, not passive recipients of treatment. They need to get into action. They need to be the captain of the team. And my job, I see my job as a guide or a coach. You know, to help people develop the game plan, get out on the field, play the game. But I can't be out there playing it for them. I want them to have a strategic biopsychosocial spiritual treatment plan in place to make sure that dealing with the whole person, and if any one of those 4 areas gets missed, it could lead to relapse or becoming dysfunctional in recovery or suffering with their pain. have to help people take action and identify red flags that show when they're going the wrong way or when they stop. The healing or recovery process is like walking up a down escalator. A lot of people have a mistaken belief that if they stop and rest, they'll stay in place. They don't, they go down. And I believe there also has to be effective recovery plans for the chronic pain, any addictive disorder, and any other coexisting psychological problems like depression, sleep, anxiety, trauma, etc. This has been very fun. This is, again, my latest in the How To vlog series, and I'd really invite you to share with me more information. My email address is here. It's sgrinstead@synapse.com. My phone number for our work is there. Check out my Facebook page. I got two of them. One is Spiritual Warrior Without Armor, and then my business one is Dr. Steve Grinstead. I also have an extensive YouTube channel with almost 500 videos on it, most of them pain related. And I want to invite you, if you're living with chronic pain or have a friend or loved one who is, send them to the chronicpainanonymous.org. So thank you for being with me on this latest how-to, and please let me know if you have any topics you'd like me to cover in future presentations. Thank you.